Welcome to the MRO Exchange, Connecting Healthcare Executives, your go-to podcast for staying informed in the dynamic healthcare world, where MRO discusses industry trends and topics with prominent healthcare leaders. In each episode, we delve into the intricate landscape of the U.S. healthcare system, shining a light on the immense responsibility shouldered by providers to effectively acquire, manage, and share clinical data with data consumers. Join MRO experts and healthcare executives as they navigate the important dynamics within this highly complex environment. From the surge in healthcare ecosystem demands to the influx of structured and unstructured data scattered across diverse systems, along with the ever-growing compliance, security, and privacy expectations, the MRO Exchange, Connecting Healthcare Executives, unravels it all for you. Tune in for a comprehensive exploration of the pressing issues shaping the healthcare industry today.
Hey everybody, I'm Matt Wildman, Chief Commercial Officer at MRO. Thanks for listening in to the debut episode of The Exchange, Connecting Healthcare Executives. As many of you know, we recently reimagined our prior podcast show, Follow the Medical Record, where we will now encompass the ever-changing and ever-expanding topics within the healthcare industry into our new podcast format. I'm going to be just one of the many hosts that you'll get to know on this new podcast, and we're really excited to bring you this content every other week as we roll forward. We'll include leaders from across the healthcare sector to dive into some really interesting topics. You can learn more about MRO on our website at MROcorp.com, and I'd love to connect with all of you on LinkedIn. Our very first guest, I'm excited to welcome in James Pelletier today, our very own subject matter expert on all things healthcare quality care reporting. James brings more than 20 years of healthcare IT experience where he's done tremendous amount of work helping to drive technology in an effort to improve patient care. He spent time in a variety of roles with several different EMR companies, and he's helped grow a number of different data and analytics firms along his journey as well. But over the last 14 years, he's really been heavily focused on population health and value-based care, challenges such as data aggregation, analytics, care coordination, and all things patient engagement. He's become adept at understanding the challenges that our providers are facing on a day-to-day basis and how to help them best comply with the government regulations that continue to flow and really succeed in a risk-based world. Most recently, James has been focused on helping MSSP ACOs transition to the new QPP reporting requirements, where, as many of you know, have become mandatory as we roll into 2025, as we sunset the web interfaces and those 10 measures at the end of this year. So, James, really glad to have you on the show. Thanks so much for being with us.
Thank you very much, Matt. I appreciate that wonderful introduction.
Yeah, well, let's jump in if we could. And I think maybe the best place for us to start here is just really around some of the basics and to kind of help root the conversation there. Can you give us a little bit of a sense for the importance of healthcare quality reporting and how it serves to improve patient care, and maybe a little bit of a flavor for kind of what's top of mind for value-based care organizations right now?
Great question, Matt. The interesting thing about quality of healthcare is that it's synonymous with improved patient outcomes. Organizations around the country are increasing their number of at-risk contracts, whereby they are really sharing in the savings that they generate based on the quality of care that they provide. It serves all the different parties involved, whether it be the insurance companies, the providers, and most importantly, patients. And it helps keep everyone motivated to ultimately keep the patients healthy. So rather than just treat patients while they're sick, which is the world we live in when we think of fee-for-service, value-based care is really focused on keeping patients out of the hospital and ultimately avoiding those high-risk type of events that can to lead to hospitalizations and, of course, increase costs in order to keep that patient healthy. The story I always tell my friends when I talk about population health and value-based care is that if you know that a heat wave is coming and you know that there are certain patients that are at high risk of heat stroke as a result of that event, It's far less expensive to purchase air conditioners for those people than it is to treat them for heat stroke after the fact. And value-based care is really focused on those types of initiatives and connecting the right resources to people that need them, and to ultimately help them maintain a healthy lifestyle. When it comes to value-based care organizations and what's top of mind, any health system executive is always going to be focused on provider reimbursement and ultimately their bottom line. But the cool thing about value-based care organizations is that they tend to be the innovation centers for health systems, since a lot of the things that they're doing are cutting edge and outside the norm of the typical fee-for-service world. But beyond provider reimbursement, we're looking at things like, how do we continue to improve quality over time? What are ways that we can improve patient outcomes and really tailor our care to the individual patient and their needs? Beyond that, data is always going to be important in healthcare. Read a stat recently that 75% of the world's data was created in the last 18 months, which is crazy to think about. And that's on an ongoing basis, and it's probably no more applicable than it is in healthcare. So there's a lot of data in different places within the healthcare environment, but mining that data and utilizing that data to gain insights into, again, how best to treat patients and what engagement strategies are best to help motivate and empower those patients are, again, always top of mind for healthcare leaders in the value-based care world. They do things like care coordination. So again, utilizing those nurses and care coordinators to reach out to patients and help them throughout their journey, sort of in between patient visits. What could we do to ensure that they're getting to their appointments and taking their medications, et cetera? So care coordination has always been a big focus of theirs. And something I've alluded to a couple of times, patient engagement. What is the best channel to reach out to my patients? How can I best alert them when there's something that's appropriate, to let them know of an upcoming appointment, for example, which we've kind of gotten used to. Is a text message best? Is an email best, et cetera? Keeping up with different value-based care models. There's always new opportunities to enter into new agreements with payers, whether it's Medicare or commercial. And even employers themselves are entering into these types of agreements with health systems in order to treat their own employees and kind of ensure their employees themselves. So value-based care models, again, always changing and keeping up with what are the ways that we can maximize our benefit by entering into these types of agreements with payers. Yeah, provider collaboration. So within a particular network, how do I best allow my providers to communicate effectively and coordinate the care of the patients that they are all seeing, and deliver comprehensive and coordinated care designed around that patient? And again, last but not least, and something I've alluded to already, is the innovation part of it. So how do I leverage technology, processes, and care delivery models to drive efficiencies and improve outcomes, enhance the patient experience?
Yeah, that's incredible. Like there's certainly no shortage of things to keep track of, and kind of initiatives to drive across this. Just as I listen to you, it strikes me that kind of the foundational element of all of that is access to great curated clinical data to inform those decisions, drive those strategies across the board. And I think so much of that is a technical challenge. So kind of how do you see the role of technology kind of continuing to play out in support of all of those priorities that these value-based care organizations are trying to drive?
That is a difficult nut to crack, in that, when you think about things from a provider's perspective, it's great that I have all this data available to me, but I'm seeing many patients throughout the day. And it's not so much that I want to see all the information. I want to see the information that's important and relevant to me, and that can ultimately divert my decision-making process on how I best treat this patient. So the fact that there's all this data out there and available to learn from is great, but it's getting the right information at the right time to the right person that is the difficult part. So having these silos of data is one challenge that they need to overcome. Creating a longitudinal health record that is able to aggregate all that data from different systems and allow me to, see a high level overview of who that patient is and sort of their status in life at that particular time. It's not just about the diagnoses and the procedures that they've had throughout their lifetime, but what is their social economic status? Do they speak English? Do they have a family support system? Do they have transportation? What is their nearest food options within their physical proximity to where they live? These are all the different types of things that can be utilized in order to inform better care for that patient and ultimately connect them to the right resources for their particular situation.
Yeah. Just having a floodgate of all the data doesn't necessarily solve the problem, and we'll get into that in a few minutes if we could. But as we kind of stick to the basics, maybe just talk a little bit about kind of the key metrics or indicators that are used in healthcare today around quality reporting.
Sure. Well, there's a lot of different data points within a patient's health record. And over the last 20 or so years, we've done a fairly good job of digitizing patient records. We all remember going into providers' offices and seeing all those filing cabinets full of paper charts. And now that it's digitalized, we can more accurately slice and dice our patients into different cohorts and put people and resources in place in order to help with that particular problem. So many organizations are using this type of technology in order to create chronic care management programs. So again, focusing on those high-risk patients, potentially patients that have 2 or more chronic care conditions, and who are most likely to end up hospitalized for particular events. So it could be a nurse or caregiver that's calling that person on an ongoing basis and following up and ensuring that they're okay and kind of doing assessments and surveys to ensure that whenever possible, we can provide preventative type of medicine rather than, having ER visits. And in other cases, it may be providing medical devices. A diabetic patient that has a wireless scale in their home. One of the cool things about that is that if they are in fact compliant and utilizing that wireless scale on an ongoing basis, it's easy for them and potentially easy for care coordinators to monitor their weight, because we know as diabetic patients that suddenly increase their weight, water intake, there's certain thresholds that we can be alerted to in order to inform a strategy to intervene and help that patient before it becomes a bigger issue.
Yeah, you put a lot more onus of accountability on that proactive management of health and kind of bring the person or the consumer of healthcare into the as a member of the care team in a much more intentional way, which is great. So all of this kind of great work that's happening in healthcare today is part of an important trend forward, of course. Part of what CMS is kind of driving for these organizations that are imparting these strategies is to report on the quality that they are working to create, the outcomes that they are driving, and that comes in a lot of different forms, doesn't it? And we've got a big old bowl of acronym soup here. And so maybe just for the benefit of our listeners, let's root in kind of what those all are. So James, can you talk a little bit about like the difference between CQM and ECQM submissions, and then inside of the CQM, there's Medicare and MIPS CQM submissions, and increasingly we're starting to hear about DQMs and digital quality measures. And so talk a little bit about kind of what those are, how they're different, and what's playing out in those submission efforts today.
Yeah. So you hit on something, that's obviously very important. With these value-based care contracts, there's obviously lots of different incentives and a lot of positive things relating to, treating patients, but there's a compliance aspect of it as well. The government never does anything without making it at least a little bit difficult for you to comply and follow their rules and guidelines. So before I get into the acronyms that you just mentioned, it probably helps to kind of take a step back and think about what these organizations have been doing today and in the past. And that's the sunsetting of the web interface, which is essentially a CMS portal where these organizations are reporting back at the end of each year on the quality of care that they provided based on the quality measures that CMS has mandated that they track, and ultimately how they score them based on quality. That web interface process included about 10 web interface measures. And it was a very manual process where it was time intensive. Typically around February or March of each year, you're reporting on the prior year. And what Medicare asks these organizations to do is report on a sampling of their Medicare patients. So each measure was limited to about 250 patients that those organizations would go manually into each EHR throughout the network and pull out and extract the data in order to manually enter it back into that web interface or portal. So it didn't necessarily matter how many different systems my physicians were on or where that data lived, as long as I could attest that the information is factual and it could pass an audit. I can find that information if we were ever audited. I didn't necessarily, again, have to worry about where that data was or how I got access to it. That has since evolved, and it's really, I guess, started way back in 2015 when we first got the signs that manual process was going to go away. With the 2015 Cures Act, there was lots of different requirements of vendors, EHR vendors, et cetera, that required certain certifications and compliance in order to get to this next step, which is the sunsetting of the web interface and the introduction of ECQMs and CQMs, et cetera. Those acronyms, ECQM stands for Electronic Clinical Quality Measures, and CQMs are simply clinical quality measures. These new rules are limiting the number of measures that organizations have to report on down to 3. That's diabetes, hypertension, and depression. But the way that those measures are calculated is different based on if you're submitting via ECQMs or CQMs. The biggest difference between the two is that with ECQMs, you're really relying on what they call structured data. So the physician has coded appropriately and entered those codes in the appropriate field within the EHR. And that's what will be utilized in order to create the scores or the calculation for each of those 3 measures. With CQMs, it's actually a little bit more similar to what we used to do with web interface measures. You can extract data throughout the patient record, and it's not as rigid with respect to where that has to be documented and coded within the EHR. So they allow you to mine notes and things like that in order to see that a depression screening actually did occur, but I'm not getting credit for it as an ECQM because it wasn't coded appropriately. Again, in the web interface world with 250 sample patients, doing chart reviews was difficult, but not quite as time consuming or insurmountable, I guess I would say, as it is when you think about the new requirements for these ECQMs and CQMs, which I haven't mentioned yet, which is that it's an all payer, all patient requirement. So instead of doing it manually, I have to extract it out of my EHRs. It has to be untouched. It has to be aggregated all together and put into a new report that I can ultimately submit to Medicare. So there's not that manual intervention that we used to have. And you mentioned a third variety. Most people can kind of categorize them as ECQMs, Medicare CQMs, or MIPS CQMs. Medicare and MIPS CQMs differ only in that Medicare CQMs, you only have to report on your Medicare population. Still a very significant amount of patients, thousands and thousands of patients, if not tens of thousands for many ACOs. But that's the major difference between those two.
And then DQMs are a continued evolution of these as well, right?
Yeah. So digital quality measures is on the horizon and more than likely will take the place of these three options going forward. There's a lot of unknowns still with what DQMs will look like and how they'll be calculated, but it will likely be a continuation of this process whereby they expand the number of data sources that can be utilized in the calculation of those measures. So it won't be just limited to the EHR, but in the particular fields that I mentioned, but perhaps expanding into HIEs and claims data and other sources that are credible and ultimately indicate the overall quality of that patient's care.
So you mentioned the sunsetting of web interfaces. That goes into effect at the end of this year, correct?
Yeah. So they introduced this new option in 2021, performance year 2021, and we've been in this period of kind of the sunsetting of the web interface measures and the introduction of these new measures. So these organizations have had the ability to submit on via the new rules since 2021, but they also could do a dual submission where they were continuing to do the web interface measures as well. They've made it a little bit easier for organizations to be early adopters in that they're going to take your highest score. So you're not going to take a penalty if you just didn't do very well in your first year of trying it. And again, it's allowed organizations to kind of practice as well as take advantage of some lower thresholds where they said, well, your benchmarks are going to be lower if you do opt into this optional period. And by doing so, obviously your shared savings could potentially go way up.
There's been some movement in the past around this timeline where CMS has kind of pushed that the deadline to transition over to ECQMs out. Right now, it's set to expire at the end of this year. ECQMs are required at the beginning of 2025. Do you see any path where CMS moves that timeline again?
I think we're past the point of no return on that, to be honest with you. You know, these organizations have been pushing back on CMS for a long time to change or ease some of the burden associated with complying to these new requirements. We did see a change at the end of last year where they introduced the Medicare CQM option. So, you know, that obviously was a very positive thing for organizations, but typically what we see from Medicare is that when it's within a year, it's probably very, very close to finalized. And even getting the changes that we got at the end of last year were not even close to what was being asked for, but was certainly something that was appreciated by organizations.
Yeah.
You know, but make no mistake, this is a big change. It's a new expense for organizations that they didn't have to account for in the past. And it's a heavy lift, especially for those organizations that have multiple EHRs. There are ACOs and value-based care organizations that are on one system. And for those organizations, this isn't quite the challenge that it is for the networks that have, you know, practices that are their own entities, have their own systems, and have to obviously overcome that and aggregate that data together so that not only can they report on all of the patients they're responsible for, but they have to deduplicate those patients and ensure that they're not counting patients multiple times, because they do obviously live in two separate systems that don't know that, you know, there's data about the other patient in that other system as well.
Yes, and the vast majority of ACOs are aggregations of practices on a whole host of different EMRs. So I want to get into that a little bit too. So as we kind of compile the data to satisfy the requirements of these CQM, ECQM requirements, how are ACOs submitting their results back to CMS, and what are the requirements associated with that in terms of the qualified registries that they need to utilize? Yeah.
So qualified registries are those entities that have the ability to submit your reports back to Medicare. The qualified registries that exist are typically thought of as the ECQM vendors, or those organizations that will not only submit but also run your calculations and measures in order to see how you would score, perhaps throughout the year or at the end of the year. The outcome of working with those vendors could be a QRDA3 file, which is the aggregation of all the data from those different systems and ultimately the file format that CMS will accept. Or you can also send that data via an API or an interface directly to CMS, which is how MRO does it as a qualified registry itself.
Perfect. That's really helpful. Okay, so let's talk about getting the data out of the EMR to compile for these quality submissions and the different formats that can take. So you mentioned QRDA. Talk a little bit about the difference between a QRDA submission and that direct EMR connectivity that you just referenced, and kind of compare and contrast those two models.
Yeah. So a QRDA1 is simply a flat file. If I think about it in a very basic way, it maybe looks like an Excel spreadsheet, a download of data. And the QRDA1 standard was created again as part of that 2015 Cures Act to provide all the data that vendors like us would need in order to report on quality. So those QRDA1 files are produced by the EHR vendors. And again, there's certain rules and requirements on where the data needs to be extracted. That data is structured data. And what many organizations are finding is that those data files are not always as complete or accurate as they anticipated them to be. Some of that may be due to mapping issues within the EHR itself, or could just be confusion on where we were supposed to be documenting these codes. And so the interesting thing about flat files, and there's lots of different file formats in healthcare that can be utilized. The QRDA1 is probably going to be the most complete, but we can consume data in a variety of different ways. Some people are familiar with the other acronym, the CCDA files or HL7 feeds, and all these different ways that we can get data out of EHRs. And those are all options. But one thing that we know in analytics is that bad data in is bad data out. Sure. And when you provide a vendor with a flat file, there's no way for them to really see upstream to identify why a measure may have failed or sort of the root cause of what's going on. And so in a QRDA1 world where you're simply just passing that over, vendors are going to do the best job they can with the data that you provide, but it may not, again, be a fair reflection of the quality of care that you're providing. The alternative is to connect directly to that EHR or all of your EHRs and actually basically get read-only access to the database, so that not only can we pull from the same places that a QRDA1 file is going to pull from, but also have the ability to look in other fields where we know physicians tend to document and identify areas where you can potentially remap data so that you don't have to change the way the physician documents, or just educate that physician on where the right place is or why they're not getting credit for a particular quality measure when they should. So that type of insight is, I think, really, really valuable, because it's one thing to know how I would report based on the data that I gave you. It's another one for you to tell me, well, this is how you would score, but here's all the low-hanging fruit or the gaps that could easily be corrected in order for you to get a much fairer reflection of the care that you're providing. And last but not least, with those direct interface connections is the unstructured data. Right. I mentioned that earlier with CQMs. You can do chart reviews and you can do things like that. Flat files cannot produce that level of data and allow you to really do an intelligent review of the patient's notes. And with a direct data read-only database access like we have at MRO, we are allowed to kind of extract information out of those structured notes in order to give credit for those CQM measurements and not have the manual effort and people going into each chart individually in order to look for that data.
Yeah, and not having to fundamentally change the way in which all of these providers are documenting, because we all know, like, they're providing great care, great service, but tend to document different things in different areas. And so the pertinent information for these measures may exist in any number of different places. And so I think that's really helpful to understand kind of the value of that direct EMR database connection. And ultimately, we're trying to get to better quality, better outcomes. And so it stands to reason, like ACOs can actually generate more revenue by showing that their providers are complying with these requirements and delivering better care, and we can show that through these quality outcomes. Is that right?
Yeah, I think the key here is that most providers are providing very, very good quality of care. It's just whether or not they're going to get the credit that they deserve. And again, with the web interface, we could overcome some of those differences in documentations and workflows and things like that. But the way that we're moving, it's going to be much more rigid and difficult, especially given the volume of patients that we're now responsible for. And obviously, we hope that number grows over time as well. So yeah, it's a big challenge for providers who are obviously there to provide great care, and they don't necessarily worry so much about the documentation as people in the data and analytics part of firms would care about.
Yeah, let a modern, robust technology go kind of decipher the documentation that was created to go do this work. So, one of the things that's been interesting for me is just to kind of watch the number of ACOs grow. CMS just released new funding to help the development of kind of net new ACOs in rural markets and help defray some of the costs to get more ACOs developing and forming, so that we ultimately get more patients under the care of an accountable care organization and these quality reports. So as you're talking to ACOs across the country, like, what are you advising them in terms of as they're selecting an ECQM vendor or partner, like what advice are you providing to them in terms of how to think about that decision?
Yeah, so there are a lot of different types of ACOs out there. Specifically what we're talking about right now is the Medicare Shared Savings Plan ACOs. Mm-hmm. And not all ACOs have MSSP contracts, but most of them do. They also have contracts with commercial payers. Medicare has other programs like the new ACO Reach program. Each of them have their own guidelines, rules, and requirements, et cetera. But one thing that we've learned about quality and reporting and healthcare in general is that Medicare tends to be the first, but everyone tends to follow Medicare's lead as well. So I think this is kind of a window into the future of how we do business. And despite the fact that this is only going to be the requirement in 2025 for your MSSP contract, I do believe it's going to expand into other types of contracts. And having 30, 50 different value-based care contracts and having one place to manage them and see all that data in one place, it is intended to make it more efficient over time and more accurate over time. But we're going through the heavy lifting process now of adapting and changing and understanding sort of a new landscape of how we're going to get measured and how ultimately that will affect my profitability within each of these contracts.
Yeah, that's so interesting. Okay, so clearly we're on this evolution of requirement capability. I was at NACOS, the ACO conference a couple weeks ago in Baltimore, where there was some discussion of ACOs moving from annual reporting that goes into effect in 2025 to perhaps migrating to a weekly reporting cadence. So it just seems like technology is going to be increasingly more and more important to kind of keep pace with the regulatory requirements that these ACOs face. But so as you play ahead a little bit in your mind, like what do you see as the risks associated to these ACOs with these new requirements and complying with them? What conversations are you having with ACOs today?
Yeah, well, the risks here is, how do I perform? Organizations like this, they hang their hat on having the superior quality of care. and your success in the web interface world is not necessarily going to directly translate into the new requirements going forward. So, these value-based care organizations, again, they exist to provide great quality of care, and they are very proud of the quality of care that they provide, and they want to be able to obviously promote that in a variety of different ways. So, making sure that you are anticipating some of the challenges as you go forward. Again, I would encourage organizations to have a practice run if possible. This in 2024 right now, as we stand, is the last year for that practice run. And it may be that you will earn more money by practicing and actually getting it right. But starting next year, web interface goes away, and at being able to adapt to all the different decision-making points that you'll make on how am I going to submit, how am I going to acquire data, how am I going to deploy my staff into the field in order to identify ways to improve and to deliver the insights that we talked about earlier to the right person at the right time. So, things that we've mentioned before, how do I acquire the data? Is it a flat file integration? Is it a direct to EHR connection? Do I want to work with multiple vendors? Sometimes there are EHR companies that are promising to do a portion of this, but maybe they're not a qualified registry, so I have to go out and find that myself. It's a time-consuming and it can be a time-consuming and difficult thing to navigate. But working with vendors, for example, that have more end-to-end type of solutions that can take you all the way from data aggregation all the way through submission, who've done it before, who have worked with the ACOs like you that have multiple TINs and multiple EMRs. Maybe they have experience having worked with the EMRs that you have within your network. There's a lot of EMRs out there, and having an organization that you can trust that has experience. A lot of vendors that are entering into this space were web interface type of companies before. They were providing that type of service. Are they really the right type of vendor to work with going forward? Do they have the technology acumen that I need in order to tackle these new challenges going forward? Do they have the expertise in the new rules and requirements? It's again where the data comes from, what's allowed and what's not allowed. What are the exclusions and exceptions with all these different types of measures? There's a lot to know. And while I'm helping provide the solutions and resources to help ACOs overcome these challenges today, I spend much more time educating people on what these new rules and requirements are, because they're extremely confusing and not everyone really understands what's allowed and what's not in order for to CMS to ultimately see the quality of care that you're providing and reimburse you for that.
Yeah, I think that's really well said, James. I think you summed that up incredibly well. You've given us a lot to think about. There's a lot coming at these ACOs. There's no question. It's just really, this is about learning, education, getting started now, using this year as a test year to kind of work with kind of proven industrial strength technology to show that this is very feasibly done, and kind of hit the ground running as we move into 2025. So, James, thanks so much for being with us today and kind of walking us through the dynamics that are clearly kind of playing out real time here. For those that are interested in getting more information, where should they go?
Well, you could reach me on LinkedIn, James Pelletier. Last name is Pelletier. And my email address is jpelletier@mrocorp.com.
Great. Thanks, James.
Great to be your first guest. Thanks, Matt.
Thanks, everybody.
You've been listening to the MRO Exchange, where we connect healthcare execs. For more insights and to hear other healthcare executives' exchanges, visit the show's page on mrocorp.com and be sure to explore additional resources and thought leadership articles. You can also check out the program page on healthcarenowradio.com. Finally, be sure to connect with us on LinkedIn or X at MRO Corp. Until we talk again, this is the MRO Exchange, where healthcare execs connect.